Hello, everybody. My name is Dr. Robert Ang. I'm from the Asian Eye Institute in the Philippines. And today, I will share with you my talk on patient counseling for cataract surgery and how it's evolved. So, it used to be that when I counsel patients who are about to undergo surgery, we would talk about what cataract is and the benefits of cataract, the basics, risks of cataract surgery, remedial measures for this. And this talk will revolve around that and the fear of doing surgery. So, um, when you when you discuss this with patients, of course, there is some hesitation to proceed with surgery. Now, these are some common tools in the clinic. We teach our residents and fellows to use these visual aids because patients don't know what the eye structures are, and we want a little bit of, at least they will know what the cornea is, what the lens is, and what the retina is. I guess those are the main components of telling the patient what are the structures involved when we do cataract surgery. And then, and in the course of conversation, of course, patients can ask questions. Now, what has changed over the past maybe 5 to 7 years? The first and most important is technology has improved a lot. So, in terms of cataract surgery, phaco machines, fluidics, efficiency, chamber stability, all of that have made cataract surgery safer and faster. The viscoelastics that we use, the main goal of viscoelastics is to keep the chamber steady and to protect the endothelium. And different formulations, different brands have consistently improved this as well. So, the femtosecond laser is an addition to our tools in promoting and doing safe cataract surgery. So, we make sure that patients know about their option for femtosecond surgery without forcing them. But there is an option, and the femtosecond laser makes cataract surgery more consistent and more repeatable. So, consistency is the name of the game when you do cataract surgery. Now, comfort. Patients want a comfortable procedure, and how do we do this? We have an anesthesiologist, and we offer sedated surgery. So aside from putting eye drops topical, we give them an IV shot of some medications, and when they're calm and they're asleep, they like it better because they don't remember anything, and when they wake up, it's all done. Who doesn't want that kind of experience? So, the pre-op diagnostics have become better as well. So, biometry, we become more accurate in terms of IOL calculation. So, no matter what IOL you choose, you want to be on target all the time. Because if you are not on target, it is our fault as surgeons in pre-op planning if we're off target. And we want to detect any pre-existing pathologies. So, patients may not know that they have an epiretinal membrane. They may not know they have glaucoma. It's up to us to detect that along with cataract so that we can brief them and set the proper expectations. And of course, what improved by leaps and bounds are IOLs. IOLs before, when I was in residency training, there's only monofocal 3-piece IOL. And Zoom, 25 years later, you have one piece, acrylic, hydrophobic, hydrophilic, foldable, EDOF, trifocal, monofocal, spheric, monofocal plus, so many kinds. And this has offered both the surgeon and the patient more options for better outcomes. Another thing that changed is information availability. So for patients, everything now is online, and they usually have knowledge of what cataract is. If not the patient, then the relative accompanying the patient has read something about glaucoma, about cataract, and about the surgery. And most of the time, this is what I feel, is the patients have researched our profile. They've searched you online. They know who you are. That's why they chose to go to you. So it's best that we have a nice profile and a nice presence online in all your social media. And they know the technology, they know about laser, they know about IOLs. What about for the surgeons? Well, for us, being in meetings, being in conferences, we learn a lot from our peers. So, skills transfer and skills training are very crucial to improve ourselves and improve our outcomes. So, these avenues have made cataract surgery better and less complications for us. So, as an offshoot or as a consequence of that, the drawback is expectations have also gone up. So in terms of patient expectations, most of my patients, they feel that there will be no complications. So they feel that cataract will be smooth. They feel that there will be no downtime. The next day, they want to go to work the next day, or they feel there will be any pain. And this is something that we have to tell the patient, no, 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 this is still surgery and you need time to heal. You need time to recover. And they seem to expect that they will not need glasses after. I don't know about you, but many patients expect that everything will be quite easy and everything will be good after surgery. So we have to set the proper expectations, especially if they have pre-existing pathologies, like if they have pseudoexfoliation, you have to warn them that they might have a complication during cataract surgery. So it's really up to us to temper the patient's expectations. But as surgeons, the bad thing is we also have our own high expectations. So what kind of expectations? Actually, when we teach residents and fellows now, everybody feels that any new technology should be easy. In one try, they should get it right. And this is not the case. We still have to learn. So skills training is still important. And with new technology, we still have to make an effort. And for example, one perfect example is astigmatism management. So if your patient has minus 0.75 corneal astigmatism, what do? You have to make an effort to tell the patient that they may have better outcomes if we go for a toric lens. And if they choose that, you have to make an effort to do the measurements, to do the markings, and to do the checks after surgery. So these are all components of what we need to do. So for the surgeon, we want things to be predictable, consistent, but we have to do our part in terms of making the results better. So how do I do patient counseling now? So it's a longer process now because you have to cover several aspects. So the first part is, first we have to diagnose that the patient truly has cataract. And if the patient has cataract, then we have to explain what cataract surgery is. In my clinic, I explain the option of standard cataract surgery and femtosecond laser-assisted cataract surgery. That in itself takes about 5 to 7 minutes already. And then you have to tell them the healing part. So after surgery, if things go well, how many days for recovery, how many days they will feel some discomfort. Now, the second part of the conversation is the IOL, because they need to choose their IOL. So I tell them that these are the options. And when we discuss this, there is usually an exchange of question and answer between the patient and the doctor. And the third is any final questions, any hesitations, we want them to open up. One key element that I always teach others is you want to involve the patient's family in the discussion, because I've learned that at least in the Asian culture, after we talk in the clinic, the patient will go home and they will discuss whatever we talked about in the dining table at night. So as much as possible, I want them to remember the crucial things so that when somebody asks them during dinner, they know how to answer, or they at least know what I told them as accurately as possible. So now I still mention cataract surgery, but I shortcut even the risks and benefits. Sometimes I shortcut, and this goes with our experience. So the more senior you become in terms of skill level, then the more you're confident that uh, capsular rupture may occur, but very rarely. So you don't want to center the conversation on that. You want to center the conversation on what they will gain and what they should expect or not expect. So, femtosecond laser or not, but the other scary things, you kind of try to brush over them. Now, here is, we made this board and we put this in all our exam rooms because sometimes the patient's waiting there and they want to read something. So one column is the conventional cataract surgery. The other column is the femtosecond laser assisted cataract surgery. And we put them in a diagram. There are simple words, very easy to understand so that they can take a cell phone photo of this, bring it home to their family, and then ask. So we try to give them visual aids that are easy to understand. Now, in terms of IOL, before the surgeon can tell the patient what IOLs are, the surgeon needs to understand optics. So that's something that we need to get from our peers in conferences, from the companies themselves, because they have studied extensively optics and what the IOLs offer. And then once we get enough information to gain confidence, we usually will try the IOL on several eyes. Like for me, any new IOL, I would try for at least 5 to 10 eyes. And then I wait for patient feedback. If they're happy, I proceed. If they're not happy, I will quietly stop. So the companies know also that I gain more confidence if I have good feedback from patients. So the patients and the surgeons need feedback from each other to proceed with new technology. So in the end, most patients will say, "Doctor, what do you think? What do you think should I do?" And I would tell them that, oh, if you want the best of everything, then you will do a femtosecond laser. You will do either an EDOF or a trifocal IOL if you want more range of vision. But then, in the end, this is part of the discussion. Now, this is something that I show peers, but I don't show patients. So it used to be that the conversation is only monofocal and trifocal. And it's simple as one is distance only, one has more quantity of vision but less quality. But it has become a little more complicated when EDOF came about, because now the EDOF is in between the two. And now you have to distinguish what's the difference between EDOF and trifocal. Then the next thing is there's another category that came out, which is the monofocal plus or advanced monofocal. Now you have to, how do you reconcile this to some patient, right? So my prediction is those of us who know enough will make the monofocal plus our base IOL. No? That is your minimal offering. And then if they want more extended depth of focus, then they get the EDOF. If they want more near, then they get a trifocal. So, but we have to resolve this because there are just too many options in the market. And imagine if doctors are confused, what about the patient? So very difficult. I used to show these models. You know, some companies give us these models. A monofocal, then a toric with marks, and a trifocal. But sometimes I don't show this anymore because sometimes it freaks them out a little bit more that they have this. Sometimes I would show it just because of the diffractive rings. So only time I will show it is to explain some rings and some halos. Now, when I counsel for IOL, there are several important questions I ask. The first and most important question is driving. If a patient drives and drives daily all the time, then there's a certain fork in the decision making already that you have to preserve as much distance vision as possible. If they don't drive, then the trifocals come into play. You know, that's how I think is if they drive, then I have to tell them the trifocals will affect this. If they don't drive, then the trifocals will be better for them. Something like that. Then the job and the hobby are secondary. Now, I don't mention brands. No, there are several reasons why, and one of the funniest reasons why I don't mention brands is because after they come from our clinic and they have a price, sometimes they will compare the price of X brand in our clinic with X brand in another clinic and X brand in another clinic, and that becomes the focus of the choice of where to go. Is how much this brand of IOL is cheapest. Well, we don't want that. So I don't mention the brand. I just mention, oh, you will need an EDOF or you need a trifocal. This is my recommendation. Then I have the freedom to choose what's best for them after I calculate the IOL. So in terms of functionality, I make it as simple as possible. The monofocal IOL is for distance only. So far vision will be targeted to be good, but don't expect anything from intermediate or near, and you need glasses all the time for most of those things. If you want more more vision and you drive, please consider EDOF lens because it extends the depth of focus. You can still drive well without much glare and halos, but you get some computer vision. Now, if you want near vision, then we have to consider the trifocals, but I always tell them the far vision will not be good. So you have to choose now. Is near vision more important? You do a trifocal, or far vision more important, and you choose from monofocal or EDO. Because if I say that trifocal can do far, near, intermediate, then that's the best for everything. But then you forgot to say the quality of far vision is sacrificed. So I try to make it as simple as that so that when they go home, they kind of will explain to their family. Now, under-promising is easier said than done because you want to convert the patient for surgery and the patient wants you to say certain things like, I don't want to wear glasses anymore. Can you deliver that? You know, those kinds of things. So first, I tell them I cannot promise zero grade or plano refraction. The reason for that is I estimate the power based on a calculator, but then your eye will heal. And this opens the possibility of you may need glasses to offset that sometimes. The second is we will know only after 1 month. Don't expect that we know day 1 or 1 week because your eye is still healing. So we will refract you at 1 month, and then that's when you decide if you want to wear glasses or not. The next thing is refraction changes with age and their vision too. So I tell them that what you are this month might not be the same 5 years from now. And they understand if they will grow old, they will get weaker, things will change. So this sets up some sort of expectation for them that nothing is forever, but we try our best now to give you what you want. Now, I also tell them that there will be some glare and halos with any lens because it's so difficult to segregate one lens from the other and bash one type of lens from the other. So I give them the spiel that, oh, whatever happens, nighttime, there will be some photic phenomena. And because of your age, your vision is not as sharp as when you were young. So young, they know because their skin was better when they were young, their strength was better when they were young, and now they're old, they have to sacrifice a little bit, and that includes vision. So, cost and pricing discussions are very touchy. So, higher price, higher expectations. But one thing I know is before they even came to your clinic, usually they would have called to ask. Or when they see your clinic, they know already that, oh, this is kind of expensive. So, they're primed for something. Now, I don't discuss cost because we have a surgical coordinator that discusses this. Actually, this takes quite a while because we give them some sort of a itemized menu. It's like a menu in your restaurant. You have an appetizer, you have soup, you have salad, you have main course, you have dessert. So in us, we have first category is femtolaser or standard phaco. What is the price of What is the price of phaco? And then what is the add-on for femto? The second is these are the IOL choices and these are the prices for each. Then next is the professional fee or the doctor's fee. And then if they have, no, one thing is I always price the toric version of a lens. So if they choose a trifocal, it will be a trifocal toric price, which is a little more expensive. The reason for that is I want to be free to judge that this eye needs a toric. It's easier to tell them, oh, after we compute the price, I think your lens is cheaper than what we quoted you to be, rather than it's more expensive later than we quoted you to be. So I default to toric all the time. And then the patient and family of the patient or whoever's paying is always making the final decision. So give options. So when we close the conversation, I let them focus on choosing the IOL, but not fear of so when they go home, it's like, oh, we have to choose the IOL. Will I do a monofocal? Will I do an EDOF? Will I do a trifocal? And not, oh, should I do the surgery or not? Because if you make that their fear, then they will just decide yes or no, surgery or not. But I focus them on the type of IOL. And then I tell them, go home, don't decide here. Go home and discuss it. So the more you pressure, it's like you going to a store, right? Department store. If the sales lady is very pushy, the more you don't want to buy, right? So you go home and decide. And lastly, important to build trust with the patient. They came here because they're sick, they're not doing well, and we're there to help them. So the doctor's job is to treat them, but to make them feel good that you're treating them as well. So we use the technology and IOL that they select based on their family discussion. I always say that I'm the one doing their surgery because sometimes they feel that you make some student will do their surgery, and it's not that. And then that you will do your best. And this ending conversation is kind of, I won't say seals the deal, but I think you develop a certain relationship with the patient that you will take care of them, not only during surgery, but all the way afterwards. And it's for their well-being. So this has been my take on patient counseling and how it has evolved over the past 10 to 15 years where technology has grown better. And my name is Dr. Robert Ang, and thank you to BVI for giving us this platform to share with you our experience with patient care. Thank you.